Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
This program is presented by Medscape Education Global.
Hello, I'm Peter Ossing. I'm an endocrinologist and a trialist interested in kidney and cardiovascular complications to diabetes and how we can prevent or treat them. I've been involved in a number of trials and tried to translate the results from trials into guidelines. Thank you for joining us on this program on optimizing cardiovascular kidney metabolic care with interdisciplinary insights. And we hope you find this content engaging and valuable. I'm joined today by Debashish Banerjee and Abhinav Sharma. And would you please introduce yourselves?
Thank you very much. Hello, I am Debashish Banerjee, a kidney doctor working at St. George's Hospital in London, UK.
Hi everyone, my name is Abhinav Sharma. I'm a cardiologist focused on heart failure and cardiometabolic diseases at the McGill University Health Centre in Montreal, Canada.
Very welcome to both of you. Now, CKM syndrome or cardio-kidney-metabolic syndrome has been named or coined a few years ago and is a really important concept linking us together because we have shared patients with problems that we need to deal and solve together. It's a global problem. It's an increasing problem, unfortunately, with more than 800 million people having diabetes, having CKD, and obesity being 1 billion or more. So it's really a growing problem and a very interlinked problem. Chronic kidney disease, cardiovascular disease, diabetes is among the top causes of mortality in international surveys, and they are on the rise, unfortunately. So despite success in management of many of these complications, because of the increase in prevalence, it's still expected to be leading causes of mortality in the near future. And kidney and heart is linked in many different ways in the acute setting, in the chronic setting. And what we are going to discuss mostly today will be the chronic link between obesity, diabetes, cardiovascular, and kidney disease. The overlap between these conditions is seen in many surveys or programs, and this is from a review of different studies showing that often if you have heart failure, then half will have CKD, and other studies will show that if you have heart failure or if you have chronic kidney disease, you are at increased risk for heart failure and vice versa. And the more advanced kidney disease you have, the higher is the risk for heart failure hospitalization, and that is seen both if you look at albuminuria. With increasing albuminuria, the risk goes up. It is if you go down in kidney function GFR, then you also see the risk for heart failure going up. So in that sense, multiple studies have demonstrated how kidney disease, heart failure is linked together. And you can say that's bound by physiology. Heart function is important for blood supply to kidney. Kidney filtering is important for volume regulation, thereby important for the heart. And there are many hormones we realize that connect these organs, neural reactions that link the organs together. In a way, you can say that kidney and heart is like man and wife in a marriage, you can say, and then diabetes links it all together. And unfortunately, obesity being particularly an increasing problem, that is driving all the other conditions to a large extent. And although we have pharmacological ways to treat obesity, I think we need to address that from a societal perspective, reducing obesity more through societal measures than through pharmacological measures. Now, the CKM staging proposed from the American Heart Association from adiposity to diabetes. And one of the new features was adding in the kidney as a risk factor for cardiovascular disease. And then these links between diabetes, hypertension, kidney disease leads to the last stage where you have advanced chronic kidney disease and cardiovascular disease and diabetes. And these are the patients we are dealing with in our clinics, and we are going to discuss today. How can we handle these patients, but also how can we maybe try to avoid people from ending up in this? And if you look at different populations, then it is found that, of course, the early stages are predominant with obesity, diabetes, or pre-diabetes, or early organ damage, and encompass up to 75% of the population if you include obesity or some kind of CKD. So it's really prevalent and important that we have now different opportunities for managing kidney disease, diabetes, and cardiovascular disease. But first we need to diagnose it. Remember, it's not just about measuring glomerular filtration rate or estimating GFR, but it's also about screening for albuminuria. We'll come back to BNP in relation to heart failure. So, Debashis, you'll now walk us through one of your patients to put it into an everyday clinical context. So, please.
Thank you very much, Peter. So, this patient is Anthony. He's a 65-year-old Afro-Caribbean male, a retired bus driver, who presented to our clinic with the leg swelling and shortness of breath on exertion, particularly when he was climbing stairs over a period of a month or so. In his background, he was diabetic and hypertensive for 15 years or so. But what is very interesting is that he gained weight prior to that. So between the age of 30 and 50, when he was working in London as a bus driver, and most of the time spending during the day sitting on his seat of the bus, he gained weight, quite a significant amount of weight. He also was smoking 5 cigarettes a day. Interestingly, his father was hypertensive and sister had diabetes as well. So quite a strong family history. Now, if you look at his blood tests at the beginning, you can see that his sodium is normal, potassium is 4.5, luckily. His GFR is 41 from a creatinine of 152, but his albumin-creatinine ratio is quite high, 144 milligrams per milliliter, which I think we need to concentrate on as we go along. His hemoglobin A1c was 68, which is not properly controlled. His BNP was 700 nanograms per liter. He had an echocardiogram done, which showed preserved ejection fraction with diastolic dysfunction. And the ECG was atrial fibrillation, which also on examination, he had an irregular pulse. His blood pressure was high, 155 by 65, and his BMI was 36. And when we examined him, he had mild swelling of his feet and ankle. The rest of the examination was normal. The medications he was on from his general practitioner was metformin, 1 gram twice a day, gliclazide, 80 milligram twice a day, ramipril, 10 milligram once a day, amlodipine, 10 milligram once a day, and edoxaban for his atrial fibrillation, 30 milligram once a day. So that brings me, as a kidney doctor, to our KDIGO heat map or risk classification. Now, I'm glad that we had this because in this risk classification, Peter, what you see is from the green to the deep red, it's not just risk of progression of kidney disease. It's heart attack, it's strokes. In fact, earlier last year, from a very large database, what we have seen is that it predicts heart failure hospitalization, peripheral vascular disease, strokes, you name it. And what you will see is that, as you mentioned, that measuring albuminuria is important. On the left-hand side, you can see the risk increasing as the GFR is decreasing from more than 90 to 15. But look at the top. As the albuminuria increases from less than 3 to more than 30, the risk increases equally. So we need to be aware of both of them. And what is also very interesting for us as kidney doctors is that we have seen the benefits of the therapy according to the stratification. So this is a wonderful analysis by Dr. Butler from the Emperor trials. If you just concentrate on the event rates, you can see that from low risk, low KDIGO risk to high risk, you can see the event rates are going up. And you can see that there is an increase in the absolute risk reduction too. So Peter, now that we know this, and you were to summarize the biggest shift in how we manage type 2 diabetes and chronic kidney disease and cardio-kidney-metabolic syndrome, how do you think the guidelines are changed? What are they saying and what is so significant?
Well, thanks a lot, and thanks for presenting this case so nicely. And I think the major change is that we now have organ protection to offer, and not just risk factor control, which is also important, but particularly in diabetes guidelines, it has been recognized that we can deal with glucose management, and you can say metformin and gliclazide, typical glucose management. But today we have organ protection to offer that was demonstrated in trials in kidney disease with SGLT2 inhibition, with non-steroidal mineralocorticoid receptor antagonists, with GLP-1 receptor agonists. So these drugs should be used not because of their glucose lowering effect, that's also fine, but we have something to offer that reduces progression of kidney disease, that prevents heart failure events and prevents cardiovascular mortality. Coming back to the CKM guideline, of course, it all starts, and also in all the diabetes guidelines and in the kidney guidelines, the foundation is a healthy lifestyle. So lifestyle is still important. Physical activity, avoid overweight, obesity is important. But on top of this, organ protection has become super important. So could you point back to the risk stratification, and could you elaborate on this holistic approach? It's not just about kidney, it's really holistic risk stratification.
Thank you very much, Peter. That brings me back to the KDIGO heat map once again. And you can see that measuring albuminuria, measuring GFR identifies the right patient where we can implement treatment for cardiorenal protection. And this is what we have in the KDIGO 2024 guidelines. So it's a stepwise approach. You mentioned about the healthy eating, lifestyle changes, exercise, which is very, very important, and also stopping smoking, like in our patient. But what is very important is organ protection. And for that, now we have a whole variety of drugs. As you can see in step 1, we have the SGLT2. And that's over and on top of using ACE and ARB, which we have been doing it for more than 3 decades. And also, in the second stage, we're using other new organ protection medications. For example, GNP1 receptor agonists and the non-steroidal mineralocorticoid receptor antagonist, provided there is significant albuminuria after using ACE inhibitors. So we've learned a lot about organ protection, and now we are implementing that into these guidelines. And on top, and I will mention that once again, getting a good blood pressure control. And as you can see in stage 4, you can start even a mineralocorticoid receptor antagonist. And perhaps the other thing to highlight is that a lot of these patients do have heart failure. You did highlight in your initial discussion that half of the CKD patients will have heart failure and vice versa. So we need to make sure the GDMT for heart failure is implemented in these patients, particularly in this context, using an ARNI when there is heart failure with reduced ejection fraction. Avina, regarding the heart failure management, could you outline the key guideline recommendations for assessing and addressing the cardiorenal risk?
Absolutely, Debashish. So the most recent guidelines that came out were the 2025 Japanese Society guidelines, and there's a prior AHA and ESC heart failure guidelines to also lean on to look at how we can treat these patients optimally. As we discussed, a lot of these patients are overlapping between our clinics, and we often end up seeing them. So the question is, how do we assess risk for heart failure, and what can we do about that heart failure risk? So just so we're all on the same page, when we talk about heart failure classifications, we need to combine signs and symptoms of heart failures with cardiac structural functional abnormalities. Going back to our patient Anthony, he had symptoms with shortness of breath, he had peripheral edema, and he had diastolic dysfunction on the echo. Probably if we were to look back more, we would see a dilated left atrium, hypertrophied left ventricle, which also are clues towards this heart failure with preserved ejection fraction phenotype, which we'll talk about in a second. That needs to be corroborated with elevations in natriuretic peptides or objective evidence of cardiogenic or pulmonary congestion. And so he had an elevated BNP of around 700, which was certainly elevated in this population. So just to ensure we're talking about the same thing here, when we say heart failure with reduced ejection fraction, that's when the left ventricular ejection fraction is less than 40%. With mildly reduced ejection fraction, that's between 41 to 49. Preserved ejection fraction is greater than 50%. And improved ejection fraction is when someone had a reduced EF and they had an increase in 10 points and their subsequent ejection fraction is over 40%, which often happens with the guideline therapy implementation. Moving on, we also have the classification of heart failure, going from stage A, B, C to D. When we talk about stage A, these are individuals at risk for heart failure. So they have the comorbidity burden, such as diabetes, hypertension, CKD, but don't necessarily have manifestations of heart failure. Stage B, which is what we call preclinical or pre-heart failure, are now when we start to see structural and functional abnormalities when we do dedicated evaluation. So dilated left ventricle, or a hypertrophy of left ventricle, dilated left atrium, elevations in your natriuretic peptides, ECG changes to show LVH. So these are clues that now an individual is moving from being at risk to developing structural changes. And then heart failure at stage C is when they've become symptomatic due to our cardiogenic causes. And this is, I believe, where our patient Anthony is sitting. He's got structural abnormalities, he's got symptoms and elevations in natriuretic peptides. So he fits in the stage C heart failure. Now, once you're stage C, you're always stage C. So even if your symptoms get treated, you don't go back to stage B, but you are a stage C heart failure. And I think that's something to recognize with classification. And then stage D is when we have advanced heart failure. This is characterized by recurrent admissions to hospitals, intolerance to guideline-directed medical therapy, and other end organ dysfunction, as you highlighted, Peter, with the cardiorenal interaction. So what biomarkers do we use in the cardiovascular domain for risk stratification? Well, the key one that I want to highlight is natriuretic peptides. So by the American Heart Association guidelines, we could see with high level of evidence that in patients with dyspnea, like our patient Anthony, measurements of BNP, or now more commonly NT-proBNP, is useful to support a diagnosis or exclusion of heart failure. It's very good to exclude heart failure, and if it's very elevated, can help include heart failure. You know, this is something we have to think about in patients who are overweight or obese, because we often attribute their symptoms to being deconditioned or being overweight. But when we actually check and screen, we find that their natriuretic peptides are elevated, indicating that they have cardiogenic causes of their symptoms. So we shouldn't ignore the dyspnea in these patients. Now, in those with established heart failure, you can use natriuretic peptides for further risk stratification. You can use it to monitor potential therapies. As natriuretic peptides decrease, the potential risk of heart failure hospitalization goes down. And in patients who are hospitalized with heart failure, it's a very useful prognostic tool. So I think natriuretic peptide in this type of patient population could be extremely useful for prognostication and to confirm the diagnosis in these individuals. So I think it's a useful complement to the KDIGO stratification that you've mentioned.
So can I ask you both, Peter and Abhinav, to comment on what we should do with Anthony? So Anthony walked into our room and he said, I'm quite scared, because he saw more than one doctor in one room, and I just want to live healthily for as long as possible without getting admitted in hospital. So my question is, with what you know about Anthony, what could we have done now, or what could you have done before?
Sure, so maybe I could start it here. So as we said, it's very likely an Anthony does have heart failure with preserved ejection fraction. He also has sequelae because he's got atrial fibrillation, as a result of which he is treated and anticoagulated. His rate is controlled. But when we now want to talk about disease modification in this individual, there are certainly many things we can optimize. On top of healthy diet, exercise, we notice that his natriuretic peptides are elevated. And so when we look at his medication list here, so metformin, glycoside, ramipril, amlodipine, and doxaban, there's certain things that are missing. And we'll talk about the evidence in a moment, but an SGLT2 inhibitor would fit very appropriately in Anthony to reduce future risk of heart failure and heart failure hospitalization. So I think that would be a very useful adjunct to Anthony's therapy regimen. And the second one that we'll talk about in a bit more detail is the non-steroidal MRAs, and potentially their role in the risk reduction when someone has established heart failure with preserved ejection fraction. From a cardiovascular point of view, those would be two things to consider when evaluating and trying to help Anthony live a better and healthier life. Peter?
Yeah, I think importantly also the SGLT2 inhibitor will of course also help his kidney. And then as a diabetologist, you can say, well, metformin and glycoside as glucose lowering drugs, but he needs organ protection, and you can say today we'll probably not use glycoside as much. The SGLT2 inhibitor will probably not affect his glucose very much with the level of kidney function he has of 41. But a GLP-1 receptor agonist might also come into play because of his weight, because of the effect on kidney and cardiovascular system. So in that sense, there are many, many things that we can optimize. And of course, we also need to see if this leads to an appropriate blood pressure, or we need to do more to control his blood pressure.
Thank you very much, both of you. Now, to put things into context, we're not doing very well. And there is evidence enough now. So there is data from Swedish Heart Failure Registry showing that where we do have evidence for managing heart failure with reduced ejection fraction very well in CKD patients, from a GFR of 30 to 44, you don't do very well. In fact, triple therapy, excluding SGLT2, you can see 28% of the patients are actually taking triple therapy. in this context. Now, the other thing is with SGLT2. I'm glad, Avinav, you mentioned SGLT2 in Anthony. How are we doing in the UK right now? Not very well. So CKD and heart failure being indications in the United Kingdom, you can see that only 34% of the patients who deserve it is actually getting it. So we're not doing very well. But it is very exciting that we do have the SGLT2 inhibitors. And we have seen this consistent result from whether we use canagliflozin or dapagliflozin or empagliflozin, we see a very consistent risk reduction of close to 30% or even sometimes more of cardiorenal endpoints. And that's really, really exciting for me as a kidney doctor.
And so from a heart failure point of view, I think we can extend off of that because as we said, a lot of these therapies not only benefit, potentially glucose control, and with some therapies can benefit the kidneys, but also will help the heart. So going from stage A to stage B, these are the updated Japanese guidelines. And as we indicated, we do need appropriate blood pressure control. So that's certainly something we can work on with Anthony. SGLT2 inhibitors are indicated here at stage A and going into transitioning into stage B. And mineralocorticoid receptor antagonists, specifically looking at finerenone with the most body of evidence and linking it to these patients with diabetes and CKD. And so these are the therapies that would form the sort of foundation when we're looking at patients with stage A and stage B heart failure. Now, as we then transition into stage C and stage D, so Anthony falls in this sort of stage C category. He's got symptoms, he's got elevation of natriuretic peptide, structural changes. So what can we look at from that point of view? Of course, ACE inhibitors, ARBs, form the cornerstone of foundation here. And we could see from the updated Japanese guidelines from the reduced into the preserved ejection fraction. ARNI therapies are more strongly recommended in the reduced ejection fraction population, but there is some evidence, and especially in that mid-range ejection fraction population. Beta blockers in reduced, not as much evidence in the mid-range and certainly not in the preserved population, but sometimes we need it for rate control. As an example, our patient has diabetes, so that's something that we may need to use. And when we look at mineralocorticoid receptor antagonists, certainly evidence for older therapy like spironolactone in the reduced ejection fraction. But now in this mid-range and preserved ejection fraction population, finerenone has now emerged as a treatment option that will reduce morbidity and mortality, and we'll see some of that evidence down the road. And SGLT2 inhibitors, as we've discussed, spanning the spectrum of reduced and preserved ejection fraction populations. There are certainly other therapies that are more focused on the reduced ejection fraction group, like ivabradine and vericiguat, but they don't quite apply to our patient at this point in time. So that would be sort of the combination of therapies that we would consider as people transition from stage A, B, C, and then D, and Anthony falls into stage C. So certainly we have a lot of options to consider in this treatment program. And when we talk about evidence for heart failure risk reduction, we see that SGLT2 inhibitors across multiple trials, whether it's dapagliflozin or empagliflozin in the DAPA-HF, DELIVER, or EMPEROR program, and even the soloist with sotagliflozin, shows a consistent reduction in heart failure events amongst individuals with reduced eGFR. And so I think this really highlights that we shouldn't be afraid to initiate these therapies, even if the eGFR is less than 60, as long as, of course, their eGFR is not too low, as indicated by different various cutoffs here. And in fact, one can argue that the magnitude of benefit is enhanced even amongst patients with these lower eGFR categories. So we really want to prevent heart failure hospitalization, protect the kidneys, and so an SGLT2 inhibitor is certainly very beneficial. When we looked at empagliflozin in the EMPEROR program, EMPEROR Preserved program to be specific. And often there's a bit of hesitancy with reduced eGFRs about starting these therapies, but as we could see from the evidence, when empagliflozin is started in these patients with HFpEF, there's a typical decline in the eGFR, which then stabilizes over time. And we see that in both patients with and without CKD. So I think as practitioners, we don't need to be afraid of initiating these therapies, given their substantial protection, heart failure events and kidney events, and stability of kidney function over time.
So, I'm so glad that you mentioned about Anthony and what could you have done before. So I just wanted to highlight here, and it's very exciting from the finerenone trials, that these diabetic kidney disease patients, if we do start the finerenone on time, we can prevent incident heart failure. And then maybe, we might have missed the boat with Anthony, when he was putting on weight, when he developed diabetes over the last 15 years. what could we have done? That's the other question that goes through my mind. And finerenone definitely would have helped. And in this case, you can see that, of course, finerenone helps once he has established heart failure. Now, if you look at the kidney trials with finerenone, the other exciting bit is that when you do a pooled analysis of those 13,000 patients, you can see that across the cardiorenal endpoints, you see a consistent benefit. Now, one thing as a kidney doctor, I also sometimes face is hyperkalemia, but it is very reassuring to see in this entire program, the discontinuation was only less than 1%. Mm-hmm. This is another interesting thing we learned from these trials, that if you maintain the potassium between 2 levels, i.e. less than 5, and stop the drug when it is more than 5 and restart when it is less than 5, it does work. In fact, it worked very well in this particular trial.
And extending off of that, when we talk about individuals without heart failure, and as the patient progresses into heart failure, the finerenone trial's Fine Arts HF trial consistently demonstrates this type of benefit. So this was a randomized, double-blind, placebo-controlled trial testing the hypothesis that finerenone reduces CV death or total worsening heart failure events in patients with a mid-range and preserved ejection fraction population. So these are individuals that need to be symptomatic, LVEF more than 40%, with some evidence of preserved ejection fraction. And very interestingly, these patients could have been enrolled at multiple time points in their trajectory, near a hospitalization or while they're stabilized as an outpatient. They were randomized to finerenone with different dosing based on their eGFR, and they were matched to placebo. 6,001 people were randomized, and they were maximally titrated to their tolerated dose, with a primary endpoint of cardiovascular death and total worsening heart failure events, with a variety of secondary endpoints to confirm these types of diagnoses. Now, if you had a potassium more than 5, eGFR less than 25, or if you had recent MRA use, you were excluded from these trials, in addition to several other cardiovascular exclusions. And so overall, with regards to the primary endpoint, we saw a 26% reduction in the risk of CV death and total heart failure events. So Debashish, from the prevention point of view, transitioning to people with preserved ejection fraction, finerenone does appear to prevent and reduce and modify the disease amongst these individuals compared to placebo. This was over a median of 32 months. Now, there was also robust and sustained reductions in albuminuria. So remember, this was a heart failure trial, not necessarily a kidney trial, yet it still demonstrated this reduction in albuminuria, and so very encouraging results from the Fine Arts HF program. And when we look at the pooled analysis, which takes Fine Arts HF, the Fidelio, and Figaro, and combines them all together, we now have almost 19,000 patients, and really to look at the efficacy and safety of these molecules across cardiac-kidney outcomes. What we see here is a consistent benefit across multiple endpoints, including cardiovascular death, kidney outcomes, heart failure, composite endpoints, new onset atrial fibrillation, and all-cause mortality as well. So the fact is, when we look across the spectrum, there's significant benefit across multiple time points, indicating that this therapy is disease-modifying and can reduce morbidity and mortality amongst these patients with CKMN. Peter.
I mentioned before that GLP-1 receptor agonists were also an opportunity, and initially they were developed to reduce glucose and to also treat obesity. But then we learned in the cardiovascular outcome trials that were designed or mandated by the FDA that they also had benefits on cardiovascular outcome and on kidney outcomes later. And initially these studies were simply initiated to demonstrate that these drugs were safe, but these drugs are not just safe, but they are also, as I mentioned before in the guideline discussion, that they are organ protective and therefore need to be used in people with established kidney disease and diabetes or cardiovascular disease, as you discussed. And if we take the cardiovascular outcome trials, they gave a hint that there were kidney benefits as well, and the semaglutide was tested in the FLOW trial, which was in type 2 diabetes with albuminuria, including people, and treating them with 1 milligram of semaglutide, the diabetes dose, you could say, and demonstrating that there was a reduction in the primary outcome, which was a reduction in kidney disease or kidney trial outcome, but also including cardiovascular and renal mortality. There was a reduction in all-cause mortality. There was less progression of kidney disease evaluated by slope, and there were less cardiovascular events in this trial. And if you go to obesity without diabetes, there was a SELECT trial where the higher dose, 2.4 milligrams of semaglutide, was tested to prevent cardiovascular outcome in people with obesity and previous cardiovascular disease. And when they looked in that trial also on kidney disease progression, there was in this non-diabetic population also less progression, predominantly by less albuminuria, but also a little bit on slope of eGFR was reduced. And therefore, there are, you can say, hints that maybe also there will be kidney protection in non-diabetic CKD, but we lack dedicated trials to demonstrate that. But these trials that we have discussed here led to, you could say, the concept of 4 pillars of management of diabetes and chronic kidney disease. You mentioned RAS blockade has been around for 3 decades, SGLT2 inhibition, non-steroidal mineralocorticoid receptor antagonist and GLP-1 receptor agonist demonstrated, you could say, 4 pillars of care, and that's in a way lent from the heart failure terminology. And then we can discuss, should everybody have all these pillars, and how fast should they be implemented? That's still up for debate because we don't have trials really testing all the opportunities yet, but we have some data to suggest that combination is probably a good thing, and we'll come back to that in more details. Brendan Nguyen did a simulation based on clinical trials where both on kidney and cardiovascular outcomes there was a benefit. The more drugs you were on, the lower the risk for these adverse outcomes, suggesting that you can add the drugs and get more benefit, which is also what you see in post-hoc analysis, for instance, from Fidelity, looking at those on GLP-1 or those on SGLT2 at baseline. It was small groups and it's post-hoc. Similar data from the FLOW trial, if you look on those with SGLT2 at baseline, they also had benefit when you add semaglutide, suggesting that these drugs may be additive. That's also demonstrated in this analysis. You mentioned heart failure, so what about combination here?
Absolutely. So like you mentioned, across the CKM spectrum, when we look at heart failure, finerenone on top of SGLT2 inhibitors still reduces cardiovascular outcomes. And so we see this in an analysis that was recently published this year that amongst people with SGLT2 at baseline and even those without SGLT2 inhibitors at baseline, finerenone reduced the relative risk of CV death or total worsening heart failure events. So what this suggests is that we shouldn't just be complacent with one therapy. We should look for every opportunity possible to reduce the risk of future events and to modify the disease trajectory because they're still at very high risk of cardiovascular outcomes over time. And new data from the CONFIDENCE trial also helps to reinforce this message. This was a trial looking at the combination of finerenone and empagliflozin in patients with chronic kidney disease and type 2 diabetes using a UACR. So it was a mechanistic trial. And in this trial, there were individuals enrolled across 14 countries, 818 people were randomized, a quarter of them were female, and these individuals were randomized to combination finerenone or SGLT2 or SGLT2 or finerenone. So it allows us really to tease apart what's happening with these individual therapies using UACR as that endpoint, given the immense prognostic value of UACR. And so what we see is that while being on individual therapy with empagliflozin and finerenone does reduce UACR over time, the combination appears to be additive, that where you have much more and a much more substantial drop in UACR compared to each individual therapy alone. So this again highlights to us that the combination therapies are beneficial, they appear to be reasonably tolerated, and they actually result in greater reductions in important biomarkers that have prognostic value. Now, where you see an increase in UACR is when the therapy was stopped at the end of the trial. So it shows that for as much as possible, we should try to maintain these therapies over time to sustain the UACR reductions that we are seeing. And there was another trial that we were a part of as well, led by a group in Portugal called the Sogaldi-PEF trial. So these were patients with heart failure and preserved ejection fraction, randomized to dapagliflozin and dapa versus spironolactone. The trial was started prior to the finerenone evidence, so that's why it was spironolactone that was selected, and it was a crossover randomized trial. And very briefly, the primary endpoint was NT-proBNP, which I discussed was very prognostic. And what the trial identified was that the combination of dapagliflozin plus spironolactone substantially reduced NT-proBNP compared to DAPA alone. We do see a slight increase in the potassium, and so that does need to be monitored, and we'll talk about that in a moment. But certainly the overall safety was fairly reasonable in this trial.
Maybe just to that point, could mention that in the Fidelio trial, for instance, the combination of SGLT2 and finerenone, there was a reduction in hyperkalemia, which was also seen in many heart failure trials. When SGLT2 and MRAs were combined, you have added benefit and you have less hyperkalemia events. I think it's important to mention that at ESC, this concept of cardio-kidney-metabolic that we are discussing around is really a concept which is in many sessions here, because it is indeed something that has caught attention. And I think the great thing is that it's bringing endocrinologists like me and nephrologists like you to a cardiology meeting, and then in 2 weeks we'll have a diabetes meeting where cardiologists and nephrologists will also attend to a large extent. So in that sense, I think we are seeing more and more that these things are going well together. But how do we put it into clinical practice?
I'm glad that you asked that question, Peter, because what we need to do is we need to have more of interdisciplinary care, right? You mentioned that in the cardiology conferences, now you're seeing nephrologists and diabetologists. So similarly, in our clinics, we need to have all together sitting around the patient. And one thing I wanted to highlight was that the patient perspective is very important, what they want. So for example, a 34-year-old peripartum cardiomyopathy patient who just had a child would like to live forever, right? Whereas, not forever, but for as long as possible. Whereas somebody who's frail, reaching their 80s, what they would like to do is have as much possible time at home without getting admitted in hospital. And that's where interdisciplinary clinics are very important. Together, it also helps educate each other and educate the staff around them, educate perhaps primary care in doing this together. And we actually had some experience at St. George's, and this is our experience way back in 2017, showing that if a cardiologist and a nephrologist together with an anemia nurse sits together, they can provide better care. And now we have a cardiovascular-kidney-metabolic clinic where we are mainly treating, and again, it's an evolving interdisciplinary care. We are mainly treating CKM4 patients with a cardiologist and a nephrologist and a diabetologist, together with a nurse and a dietitian. But what we're learning more is that we need to educate primary care. For managing CKM stage 1, 2, and 3, we need to work with primary care and educate them. And that's the next step in our model.
Great. And so, Debashish, I'm really happy you mentioned this sort of model of multidisciplinary care. And certainly from a cardiovascular point of view, there is still a lot of therapeutic hesitancy. There is a lack of prescription ownership. Who exactly should be the one? Is this a diabetes drug, a weight loss medication, a kidney medication? Who should be the one to write the script and go through the side effects and issues with the patient? And there's a rapidly changing landscape, starting with type 2 diabetes, as you said, Peter, now evolving into kidney and into heart failure. And so it can be overwhelming sometimes at times with the variety of options. And of course, there's also adverse effects. As cardiologists, we're very used to certain classes of medication, but less used to other classes. So how do we learn from each other in order to address these side effect profiles to give the best therapies for our patients? So in reflection to your example, I want to highlight that in Canada and maybe in many places, we have what we call asynchronous healthcare, where a patient may see multiple specialists, but it's delayed over time. So they see one physician and then another, and often very little is optimized or changed, especially in these CKM4 patients, because they have so much going on. It becomes very difficult for one individual to change, and there's a lot of therapeutic hesitancy. So we developed this program called the Decide Cardiovascular Program, where a patient would be seen in a multidisciplinary care clinic at the McGill University Health Center simultaneously with a cardio, endo, and nephrologist. And almost like a tumor board, this patient can see all the specialists at the same time. Multiple issues are addressed at once, all the questions are answered, and then eventually over time, the patient can be transitioned into community follow-up with an appropriate plan. And so when we looked at guideline-directed therapy initiation before and then after, we see substantial increases in SGLT2 use, GLP-1, RAS blockade, and MRA use over time. And we predominantly take care of the sicker CKM patients where, as you rightfully highlight based on data coming out of both Europe and the US, they're not being optimized. And what we also saw was a deprescription of therapies that just don't have prognostic value, like sulfonylureas, DPP-4s, and insulin. And so what we see is that these type of asynchronous care does not necessarily lead itself to optimization of GDMT, especially in these very sick CKM patients who disproportionately utilize the healthcare resources because they get admitted and they need more care down the road to deal with their complication. This type of synchronous healthcare model may be something where we can enable timely access to a healthcare provider so a person is not waiting a long time to see individual specialists. Collaborative decision-making can occur right on the spot, and optimal use of GDMT can happen with reduction in appropriate biomarkers and outcomes over time. And to your point about hyperkalemia risk, I think having a nephrologist in the room when we're talking about hyperkalemia is very reassuring. Having an endocrinologist in the room is very useful when talking about hypoglycemia or hyperglycemia. And having a cardiologist there is very useful when talking about fluid management and blood pressure. So I think working together leads to much better outcomes amongst these patients with CKM, and especially those with the stage 4 CKM.
So that has been fantastic to discuss this with you. And to sum up, any particularly final comment from each of you?
Thank you very much, Peter. I think for me, it's an exciting time to be a kidney doctor, working with my colleagues like you across specialties and primary care, we should not forget them, to improve the health and quality of life for our patients like Anthony.
And I would like to extend off of that by saying that really multidisciplinary care models are very critical to optimize and implement these life-saving therapies that really do change the trajectory of these patients and change their outcomes over time.
Well, truly a fantastic session. Thanks a lot for all your insights and your knowledge and putting this into clinical practice. It has been a fantastic way to show how we can unlock the potential of the many treatment options we now have today that we never had before. So thanks for participating. Thanks for attending this session. And please continue to answer the questions that follow and complete the evaluation form. Thank you very much.
This program was presented by Medscape Education Global.